Welcome to I'm Not Sleeping, I'm Drooping.
I'm excited. What a great title.
We have 5 cases. We want to test your recall of 5 different things that cause ptosis. Buzzwords.
We've got mitochondrial disease, normal pupils, and bilateral and progressive.
Have you figured out this ptosis yet? Let's watch a video. This is what you might see with a patient with this type of acquired ptosis. Pupils are equal, normally reactive to light.
He's got a really nice iris color.
That is really nice. Eye movements are a little limited. Some causes of ptosis do cause eye movement problems, some don't. And both eyes just look a little droopy.
Yeah, but I think it's helpful to really see those limited EOMs in this guy.
Yes,
Look at
indeed. So we have something causing a ptosis and eyeball movement problem as well. Did you figure it out?
I did, but let's see if they did.
This is what it is. Well, there's actually a couple things that cause the myogenic ptosis. CPEO was what we saw in the video, a mitochondrial disorder. And you can pause and read some more of this information here, but some characteristics that we highlighted that should be remembered for CPEO. You ready for the next one?
Let's do it.
Ptosis number 2. Buzzwords.
So here are your buzzwords. You've got a fluctuating ptosis. It improves with tensilon. And acetylcholine receptors.
Something going on. Let's take a look.
Giving it a workout of the eyelid. Remember, the eyelid contains levator palpebrae superioris and Muller's muscle supplied by the third nerve and the sympathetic chain respectively. So over time you'll see, look at my finger now, that the eyelid has begun to droop even further when you challenge it or check whether or not there's fatigue.
Getting tired as the eye's being used. In this case, one eye, but it could be both eyes.
Yeah, and I think it's important to note that his pupils are not involved, and there's, yeah, I think it's, although use a better target than your fingernail when you're doing this.
Good call. One more video of the same condition if you haven't figured it out yet. In this case, turned out the left eye was more affected than the right. Could be the right, of course, that's affected. Just look like tired, fatigued eyes. Do you know what it is?
I think so.
Let's
what do you
find out.
got?
I got myasthenia gravis. So myasthenia gravis, I've seen a few patients with this, and their eyes just get progressively more and more tired. Tensilon is the gold standard test, which would reverse the ptosis in this case. But one of the hallmarks is fluctuating ptosis. Sometimes it's good, sometimes not so good. You ready for the next one?
Let's do it.
Ptosis 3. Buzzwords.
You got sympathetic. You've got anisocoria that's worse in the dark. And aproclonidine improves. What do you think it is?
I don't know. I'm thinking sympathetic. There's a lot of things that could do that, but let's take a look. So this looks like a pretty dark room. A slight ptosis in the right eye. It doesn't look complete, which makes me think probably something with Mueller's muscle.
Ooh, that anisocoria in the dim light.
There's also some anisocoria in the bright, but I think it's worse in the dark. At least there's a lag to how the dilation occurs. And then aproclonidine is used. And that right pupil went from being myotic to being almost super sensitive and very dilated. And there it is. Did you figure it out?
Well, I think it's a Horner's, Dr. K. Kenworthy.
There it is. What caused it? A lot of things can cause it. Anything along that sympathetic pathway. This patient was right carotid dissection.
And I think we need to stress out that if a patient comes in with a painful Horner's, it is an ICA dissection until proven otherwise.
That is actually a good idea. One more video just showing a different patient, same problem. Which eye has the smaller pupil? Is this a right or a left Horner's? Right pupil dilates normal, quick sympathetic speed. Left eye doesn't have that sympathetic turbocharge. And there it is, left eye. Horner's. So I think it's important to remember Mueller's muscle. Also, sometimes we get what you were telling me before as a sort of reverse ptosis. Would that be from inferior tarsal muscle?
Yes.
Okay.
Yes.
And gets better after aproclonidine.
Yeah, I think the only other point that I would note on this, especially since we had that great video of the dilation lag, is when we are talking about pathologic versus physiologic anisocoria. Anisocoria that is physiologic will not have that dilation lag, while if it's a pathologic entity, it probably will present with that really nice video.
Good point, and that comes up a lot. Physiologic anisocoria, has it just always been this way? Something pathological, great point. Ptosis 4, buzzwords.
Levator innervation defect. The eye movement is abnormal, and there's an ipsilateral ptosis.
So just one eye, and eye movements are affected, and something is losing innervation to levator. Let's take a look at a video. I sometimes get nervous when I see this, because sometimes it can be a very serious problem. This case I'm feeling a little better because at least I notice pupils so far. It's hard to see under that ptotic lid, but I think pupils are pretty equal. Patient's trying to look. They do a nice job abducting, which is abducens, lateral rectus.
But can't really look up too well, huh?
Can't look up, can't look down. And ptosis affecting levator. What do you think it is?
Well, whatever it is, it's not good, Dr. Kenworthy.
It's
not good.
It's not good. It's not good, and if that's what we know for now, that's great. Third cranial nerve palsy, causing that one-sided problem. Eye movements were abnormal. What do you think if the pupil was dilated?
Well, if that pupil was involved, this is going to become an ocular emergency pretty quickly here. I mean, we need to make sure that this patient gets out of our chair and gets the help, just to make sure that we're ruling out any type of aneurysm or compressive lesion that is running along cranial nerve 3 and those pupillary fibers that would cause that pupil to have some of that involvement.
Yeah. If the pupil's spared, I think most of the time we can think it's a microvascular ischemia. Usually will resolve on its own after about 3 months, but definitely a good point. If that pupil's involved or we're concerned about something else, that patient's being sent out for imaging quickly. Last one, bonus. I don't even have buzzwords for this one. I have a video, though. You ready to see it?
I am.
Let's take a look. Ooh.
Oh,
You told me this was one of your favorites.
this by far is one of my favorite conditions.
So child is sucking using the pterygoid muscle, which is innervated by V3 of trigeminal. And we're also seeing the eyelid moving. Why would that happen?
I don't know, but can we watch that video one more time?
Absolutely we can. Isn't that great? So remember, eyelid, orbicularis oculi facial nerve, is going to be closing the eye. But in this case, is that really the problem? Or is it the levator lifting the eye? I kind of watch that video and I say, well, is it a problem with the eyes closing or is the eye opening? What do you think is happening?
That's a really good point. What cranial nerves are the ones that would be involved in this condition?
Let's take a look at it. Marcus Gunn jaw winking, trigemino-oculomotor. So oculomotor is innervating which one? Levator. So this is actually the eyelid being stimulated to open more. So this is interesting.
Yes.
Somebody with Marcus Gunn naturally has a little ptosis. But when the pterygoid muscle is being used to open the mouth, it also stimulates levator, so the ptosis is diminished because levator is being stimulated by that synkinesis.
Yeah, you got it. And this is always why it's great to ask your parents that come in with this, your little baby's looking like this, is if they notice any changes when they're drinking their bottle or sucking on a pacifier.
This has been fun. Keep studying. We covered these conditions right now. Anything you wanted to add?
No, I think that you guys are going to do great. I think that go back to the class notes. Kenworthy had some amazing content for you in first year, and I think, reaching back into those archives, you can listen to it on 2x speed. I'm sure it'll give you the same effect. But really being able to tie in the anatomy and the physiology into some of these conditions that we're going to be able to talk about is really going to give you a deeper understanding and a better way to navigate and work through the test questions as you take that. So good luck. You guys are going to do great. We're rooting for you.
Good job. Thanks. This was fun. Esposito worthy.
Esposito out.